Hi everyone, my name is Tashelle and welcome to The Journey. Today's topic, as you can see, we're going to be talking about neurological dysfunction. Now I know neuro can be a big headache, hence the fact that we're talking about the head. So let's just go ahead and get started. So today we're going to first talk about how the brain works. And sometimes when you get an understanding of how the brain works, then you can see exactly where the dysfunction is happening, okay? So here I drew a picture of what dendrites, axon, and a cell body looks like, okay? And pretty much these are what's going to represent nerves that are going on within the brain. And you have thousands and millions of nerves or neurons that are going throughout the body. And one thing with nerves is that we know that they do not regenerate, right? After a while, the amount that you were born with is the amount that you are going to have, and they're going to mature and get better and stronger. And once they're damaged, they are completely gone, okay? So when it comes to anything neurologically, you want to make sure that it stays intact, okay, as best as you possibly can. So again, we're going to be talking about the neuron, okay, and you can think of neurological. It's in the word neural, okay, so neurons. So we have the dendrites, which the dendrites are responsible for receiving information. So they look like branches, okay? Forgive me with my drawing, but they look like branches. And if you can for those of you guys who are visual learners, you guys can use this picture to understand exactly what is going on within the brain. Even right now, as I'm giving you the information, you're receiving the information, your dendrites are taking those information. So think of it like branches, like hands, right? I'm receiving something. You give me something, I receive it with my hands. These are how your dendrites are working, okay? Then I have my cell body, right? And the cell body is where you see the nucleus is occurring, okay? So that's why I have the nucleus here, so that way you can pinpoint that is my cell body. And the cell body job is to analyze the information, right? It analyzes the information. So you can think of it like this, right? I have my hands, which are like my branches, right? I receive the information, then the cell body is going to analyze the information, right? Because now that I got that information, I got to figure out what am I going to do with it. So I'm going to analyze the information. Then once I've analyzed the information, I have my axons, which is this area right here, and it's going to carry out the information, okay? So now that I've analyzed, now what am I going to do? All right, and that's pretty much what the axon job is, responsibility is. It's carrying out the instruction that was given once it was analyzed, and how the information was given was through the dendrites, because the dendrites are responsible for receiving. And as you can see here, you have the dendrites, you have the cell body, you have the axons, and which is connected to another dendrites, cell body, and axons. And again, another cell, dendrites, cell body, axon. And you just see a long chain of these different things until they finally go to the different parts of the body that needs the information to be given to, okay? And for an example, so that you guys can understand, okay, bear with me. Think about when I touch a hot stove, right? I touch the hot stove, right? How do I know it's hot, right? Because all this is going on neurologically wise, right? So I touch the hot stove. Once I touch the hot stove, right, my dendrites receive the information and say, hey, this thing is hot, right? So the information was received through my body that whatever surface I'm touching, it is hot. So now the cell body job is to say, okay, what are we going to do? It's hot. Are we going to leave our hand there, or are we going to move our hand away? Is it going to destroy our body? Is it going to harm us? This is a harm. So we're going to go ahead and move away. So once the information has now been analyzed, the body is now going to say, okay, this is what I want you to do, right? So I want you to move away. So the axons then now say, okay, I got it. The instruction is to move away, withdraw the hand, right? So then it carries this signal. This dendrite received, hey, the surface is hot. It analyzes, move. It carries, okay, let's go ahead and move. And it continues to follow those same path until it finally gets to wherever it needs to get to in the body. And let's say, right, I have those nerves that kind of go along my hands, right? And they send those signal from the brain, it sends those signal down, right, to those neurotransmitters, right, and the neuromuscular part of your body, and it says move your hand, and then finally you move your hand. Now you can say, wow, but that happens really, really fast, right? And this happens within nanoseconds. very, very, very fast, because the minute you touch something hot or something that is going to give you harm, or even a needle prick or something, your body reflexes very, very fast, right? So all of this thing is happening in nanoseconds, all right? But I just want to get you guys to understand what's going on in the brain. And so now that you have the dendrites, the cell body, and axons, right? You're probably wondering, what is this thing here that I've tried to draw, right? And these are the myelin sheath. And the myelin sheath is pretty much, it's like a wrapping, insulation that coats around the axons. And what it does, it better send the signal a lot stronger and better, okay? So one way you can remember myelin sheath, think of actual cable cord, right? Or any type of cord, or you can think of your chargers, or anything that you have to plug in, right? If you was to strip what was covering the actual cord itself, you will find that there's a lot of wires, and you've probably seen them. You've broken a couple of them, or you've seen them ripped in half. Or sometimes you're trying to save money and not buy the actual charger again, so you're taping different things on it so that way it kind of get a better insulation. So pretty much that's the same concept. So some cells will have the myelin sheath, other cells won't have the myelin sheath, depending on where in the body they are located and the need for them. So pretty much the purpose of it is just better insulation, right? I can send the signal a lot faster. I can get things done a lot quicker because it has a protective layer on it. So you just think of like a cable cord or any type of extension cord or anything like that, right? All the wires are all protected. They're never exposed, right? They're always protected. Why? Because that surge of electricity that's going from one place to the next has more strength, more power to get through where it needs to get to because it's protected. Okay? The minute those wires are exposed, sometimes you may get it to work, but it's going to be weak. It's not going to be as strong, as effective as it needs to be. So now, you're probably saying, why am I telling you that? Why does that matter? Okay? It matters because there's different parts in the area when you get to neuro where you will see white matter and gray matter. And you may say, what is white matter? What is gray matter? White matter is any area in the brain that has the myelin sheath or has the myelin layer on it. Gray matter is going to be just exposed, okay? So you're going to see different neurological dysfunction happening in different areas, and you may hear the term gray matter or white matter, and you're probably saying, what is the difference between gray matter and white matter? And the only difference is pretty much the myelin sheath that's on it. So this is the first thing that's going on, okay? Now I'm going to go ahead and draw the actual brain and show you exactly the different parts and components of the brain. So now we're going to be talking about the brain. So as you can see here, I did my best to draw a brain. And within the brain, right, you have different compartments. So in the front, you have your frontal lobe, right? On the sides by your ears, okay, you have the temporal lobe. You have the parietal lobe, which is up on the upper part, which is right here, okay? And you have both sides, our parietal lobe. And then you have the occipital lobe, which is the very, very back part here. And then right under that, the lowest part is your cerebellum, okay? So now you're probably saying, okay, what are all these for, okay? So your frontal lobe is the area where you have your personality. That's where you have your rational thinking, right? That's where what makes you you is right in this area here, okay? Your decision makings, okay? Your personality, your rational, critical thinking, right? All of that information, right, is all right here in this front area. Then you have the temporal lobes, right, which are by the ears, or try to at least remember that they're by the ears. And what they do is they help with sound. So I put here music symbols or whatever so you can see you're listening to something, right? Or you listen to me speak right now. And then you have the parietal lobe. It has many different functions, right? But one thing that I did remember was it deals with touch, right? Sensation, things like that in that nature. So that's why I put like a hand, right, for touch. And then you have occipital lobe, right, which your occipital lobe deals with your eyes, right? So it's in the back and it functions that area with the eyes. And then you have your cerebellum. And your cerebellum, if you notice on the brain, it has like ridges, okay? It has ridges. So that area of the brain, just know that that is your cerebellum. And I put a little scale here because that is where your balance, it deals with balance, okay? And then coming down here, you have your midbrain area, Okay, you have your pons, your medulla oblongata, and then you have eventually this will work its way down to the spinal cord. Okay, and then the spinal cord would then separate and have different trails of nerves going different places, and they call that the cauda equina, which is pretty much Latin for horsetail because that's exactly what it looks like. So it will continue down until it reaches those branches and it goes down as low as your lumbar area. Okay, and until finally it works its way to your legs and your toes. So with that said, there's certain things that I want to point out from here that is a must know so that way you can understand when you begin to have the neurological dysfunction, you know why it's happening, okay? Because of where the damage is taking place. All right, so I'm just going to come over here, and there's this portion of the pons. Within the pons, it helps to regulate with respiration, believe it or not, right? So if you have trouble breathing, all of a sudden when you are fine, you know, this is, and it's, you're coming in with a neurological problem, this is something that you want to pay attention to because you want to know, okay, where is the trouble occurring? Or if the trouble is occurring here, what can I expect, right? So if this is regulating respirations, there may be something wrong with your breathing, okay? Then you have your medulla, which is short for medulla oblongata, but everyone knows it as medulla. So you can go ahead and say medulla. And this carries a big portion of things. And within this, it has reflex centers for respirations as well. So it's not just only the pons, but you have your medulla that deals with respirations, right? It also deals with blood pressure, your heart rate, coughing, vomiting, swallowing, and sneezing. You're probably saying, okay, why is that important? Because sometimes when you're doing your neurological examinations or assessments, you check for a gag reflex, right? When you put something down, or if they can swallow or something like that, right? You're checking for that. If a person is able to cough, I know they have a gag reflex, right? If you're vomiting, sometimes when you're vomiting, you gag, right? And again, I need to know if you can swallow. Okay, and then it also deals with sneezing as well. Then you have the reticular formation, which the reticular formation deals with the arousal and sleep-wake cycle. Okay, so arousal and sleep-wake cycle. All right, so these are the main components that I want to mention. Okay, and then now you have around the brain, you have a bone, a very hard bone that is there as a function to protect the brain because the brain is like a sponge. Right? Literally, if you hold it the wrong way, you can damage the brain, right? So you have to have some type of protection. So you have the skull, and the skull is what protects the brain, right? And you will see different suture sites or fissures along the brain for the actual skull, right? Where they will connect and fuse to protect the brain, right? And it protects all aspects of the lobe, all parts of the brain. And you can feel it. You can even touch your own head and feel exactly where your skull ends. And then you have CSF, and you might say, what is that? Cerebral spinal fluid. And with the cerebral spinal fluid, right? As you can see the little squigglies in between, right? You're gonna have the fluid there, and what it does, it protects as a cushion. Okay, it gives it the brain movement, momentum, right? When you have something like a sponge, right? You have a sponge there, it's just there and it's dry, right? But when you have cerebral spinal fluid, it can also works as a cushion. It works as a how can I say, keeps the brain hydrated. It allows different things to pass through the brain in those areas. Okay, it can also be a way of transporting different things, right? It absorbs different things. It's just a way of travel, right? And if you think about it, if you just had a sponge there and it was just dry, right? Eventually, it's not going to work the same way, right? And you don't want the brain to not have any fluid because then the brain would just kind of just flatten out. And you don't want that. You want it to give it a body. So what the fluid within the brain is doing is it's almost as if it's lifting it up, okay? Keeping that cushion, keeping that how would I say it? It's keeping I guess a good momentum, not momentum, but a good protective cushion, okay? Is what it's giving it. And it's also, the brain is not dry, it's moist, it's given the nutrients that it needs, different functions that's going on within the cerebral spinal fluid. So now I'm going to go ahead and talk more about the cerebral spinal fluid, and then I'm going to talk about the sleep-wake cycle. Last thing I want to mention within the brain, okay, is the ventricles of the brain. Now, the ventricles of the brain, you have 4 different types of ventricles, right? You have a left and right lateral ventricle here. Okay, you have your third ventricle, which you have within the third ventricle, there's a hole there. And if you guys remember in science or just in anatomy, anything that has a hole normally has the name foramen in it. Okay, so this hole is referred to foramen of Monroe, or it has a newer name, but either or can still be the same. Intraventricular foramen. So you take your pick, which one is easier for you, or which one you remember a lot more. And that is your hole that is right there in the third ventricle. All right? And then you have your fourth ventricle a little bit down here. And from there, eventually, it just goes down and it fuses, and you have what they call the central canal, okay? And it goes all the way down through the spinal cord. So these are your different ventricles. You have 4 different ventricles, all right? Within the ventricles, you have an area that's called the choroid plexus. And within the choroid plexus, which you can see here, all right, it's responsible for creating cerebral spinal fluid, right? And cerebral spinal fluid, again, like I said, it's just fluid that circulates around the brain and the spinal cord, okay? It kind of gives it elasticity. It helps to give cushion and provides ways of traveling different materials up and through the body. All right, at least within the neural part. So the CSF is a clear fluid that is produced in the choroid plexus of the ventricles. And again, like anything that has fluid, there's always the risk or potential of having a blockage or having an obstruction somewhere along that area. So anything that is going to obstruct or block the cerebral spinal fluid, right, or maybe produce too much at a time, you have hydrocephalus, okay, and hydro, okay, is fluid within the brain, right, because it's a buildup of fluid because, there's a blockage or there's an obstruction somewhere. All right, so now we're starting with neuro, okay, so the before that was just background information to kind of get exactly what's going on. Now we actually start. So first thing we're going to start with is level of consciousness, which is also known as LOC or LOC. Choose whatever you want to call it, but just know that we're talking about level of consciousness here. So what is level of consciousness, right? It's your level of responsiveness in these areas. You have your mental status, your intellectual function, right? Your thought content, emotional status, and language ability, right? And all of these things are going to encompass how conscious are you, okay? And with mental status, you may say, okay, is that just only, if I can think, can I add, can I subtract, cognitive area? And that does not mean that at all. Mentally, it means, are you stable, right? And a stable person is someone who's well put together. Their appearance, look well groomed. Their behavior, they're not just, lashing out at you or being angry or having an attitude. They're able to compose themselves. And those are the things that are in mental status. Along with is a patient AO times 3. Now you may say, what is AO times 3, right? And you're going to hear this a lot within the hospital setting, or if a doctor is asking, what is the patient's level of consciousness, or what is the patient neural status, right? And that's a short thing for, is the patient awake, alert, and oriented to either time, place, or themselves, right? And that's a big thing. So if they're able to answer correctly to each thing, then they get three because it's 3 different categories here. So it'll be AO times 3, okay? Some facilities, like some hospitals, they do AO times 4, which you don't really have to do. I know my facility, we just strictly do AO times 3. Are you oriented to yourself, to the time of the day, whether you're talking about, the month and the year? Most of the time I just ask for month and the year because I myself don't always know what actual day it is. And you can ask them, do they know where they are right now? And sometimes they'll say they're in the hospital, they'll actually give the name of the hospital, or sometimes they just would not know. And that gives you an idea of how well their level of consciousness is, all right? Next thing is intellectual function. So this is the one that is dealing with strictly cognitive ability, right? So I'm going to ask the patient, okay, subtract 100 from 7, right? Or I may ask them a question that's going to give me your rational ability, right? How well can you rationalize? How well can you critically think? So they may have a question where they ask, what does dogs, horses, and cats have in common, right? And you may be wondering too, oh, what do they have in common? Well, for one thing, they all have 4 legs, right? So this is going to, check out your cognitive ability, okay? Or they're all animals, either or. So now I have my thought content, right? And your thought content, you're gonna, look out to see if the patient is experiencing illusions. Do they hallucinate, right? Do they just have spontaneous behavior where they just have a subtle urge to do something, or does it just come natural to them to do certain things, okay? So those are the things that you want to watch out for when it comes to the thought content, right? Are they making sense? Then you have emotional status. Your emotional status is, of course, big hint, emotional, my emotions, right? Am I going to be anxious? Am I worried? Right? Do I have mood swings? And flat just pretty much means I'm talking like, oh, I have no idea what's going on at all, right? When someone's telling a story and it's like, okay, you have no enthusiasm, there's no tone between, are you happy, are you sad, are you, it's just strictly flat, okay? So that's what flat affect is. And then you have language ability. So my language ability, right? I want to make sure, are you able to speak, right? Can you speak? Can you write? And then what troubles do you have with speaking? Because you are going to come across people who are not able to speak, right? They have trouble speaking, trouble expressing themselves, right? Which those are called aphasia, all right? It's a term called aphasia, which I'll get into more when I get on the topic of strokes. But just keep in mind, right, their language ability. And all these components is your most important indicators of letting you know a patient's condition, right? Because neuro-wise, these are the first things that you're going to see in a patient that is well, that, they have their level of conscience and it's intact. A patient who's not doing so well, right, and we're talking about neuro, right, this is going to be your first indicator, right? As a neuro patient who's going through something neurologically, these are going to be your says of, hey, what's going on with this patient? So I'm going to go over some terms that are very important to know. So first thing first, right? You have your altered level of consciousness, which I kind of brushed upon briefly on the last one, right? If they're not able to answer all of the answers of person, place, or who they are, of a time, right? They're going to have an altered level of consciousness. So what is the actual definition of that, right? Is a condition of being less responsive to and aware of environmental stimuli, right? So they're not oriented all the way, right? So they may be at AO times 2, AO times 1. Sometimes they only know themselves, or sometimes they don't even know who they are, right? So there's an AO times 0. They're not oriented at all, and that is an alter in your level of consciousness because you should be able to answer those questions, right? All right, so the next thing we have is akinetic mutinism. A means against, kinetic means movement, right? So what's this going to tell me here? Which I already kind of see, I'm moving ahead, but it's pretty much unresponsive to the environment, right? The patient makes no movement, right? No movement or sound, but sometimes they may open their eyes, all right? So akinetic. A means against, kinetic means movement, right? So they're going to have what? No movement or sound. They may open their eyes sometimes, all right? So that's that. Then you have locked-in syndrome. Locked-in syndrome. So with locked-in syndrome, right, the patient is unable to move or respond. You may say, oh, this sounds just like that one, right? But they may be able to move their eyes. So they are able to move their eyes, right? And this is due to a lesion, right? Or lesions that are affecting the pons area, right? So remember when we was going over the pons and I mentioned the pons area, okay? And then you have their cognition is intact though, all right? And with these patients, Okay, I think that this is the worst one to have, and why I say that, right? I don't know if you guys, I don't know if, I forgot what's the name of the movie, but they did a movie where pretty much it was this lady. She was going into anesthesia. They had drugged her to go in for surgery, and she could still feel everything, but she couldn't tell them, right? So you know, cognitively she was there. You know, she was able to, you know, everything was there, alert. But she wasn't able to let them know, like, hey, I'm still feeling everything that's going on, right? So that's how I think of locked-in syndrome. Everything is still intact, right? But it's like you just can't move. You can't move. You can't talk. You can't do anything, right? But your cognition is there. You know what you want. You know, and I feel like that is the most frustrating thing, is to know what you want to have done. Your mind is completely there. You have people treating you like, can you hear me? And you're like, man, I can hear you fine, right? But you just can't respond, or you can't move. So think of it being locked in. I am locked in. Literally, who you are, what makes up who you are, it's locked in inside in a body that is not able to move or function the way it needs to function, right? So somewhere neurologically, things have been damaged, which it's within the pons area, right? Because either a lesion or whatever it is that is going on, right? And you are locked in. All right, so that's why it's called locked-in syndrome. So you're there, the essence of who you are is there, but you're just not able to express or communicate that out through movement, sound, or anything, okay? So remember, this differs from this one, because this one you cannot move or make a sound. You may open your eyes. This one here, you can't move or make a sound. You can open your eyes, right? And cognitively wise, I am all there, okay? So just remember that. And now, persistent vegetative state, right? A persistent vegetative state is a person who has sleep-wake cycles, right? So it's not like they're completely gone. They do have those sleep-wake cycles, right? But they do not have any consciousness of what's going on, right? So they have no cognition, which differs from this one, right? So I'm stressing these things because I want you guys to kind of pick out the different things that that these terms are attached to, right? So locked-in syndrome, they have their cognition. Persistent vegetation, there is no cognition, right? This one, they have movement, right? I mean, they have no movement, right? And then this one here, you know, it's just altered a little bit. So I just want you to like kind of see where exactly the differentiation is taking place, so that way you're not mixing up all these terms, because they do sound a lot alike if you just read them by, right? But I want you guys to kind of see the differences, because a lot of times on the test you may have some definition questions and you're like, oh my gosh, I can't answer this question because I don't know the definition of what this thing is. So then you miss out on two questions, because you know one is actually the actual definition, and then one is using that same term, you know, in a question. And sometimes you can use context clues, but then other times you're just like, you know what, I just do not know, and I'm not going to know, right? So kind of remember these terms by what their differences are. Okay, so persistent vegetative state, right? I still have my sleep-wake cycles. I have no cognition whatsoever, no consciousness, and I have no effective mental function, okay? I have none of it at all. So think of it like a vegetable, which is why they call it vegetative state, right? A vegetable is just there, right? So these are your terms, and I still have a couple more to go, but just start trying to see what makes what different from each other, so that way it's not just all sounding all the same. Okay, so last term is you have coma, right? And coma is like the worst thing out of all of them, right? And it's pretty much a prolonged unconsciousness and unresponsiveness, right? So you cannot be aroused, right? There's nothing going on at all. At least with the vegetative state, you did have the sleep-wake cycles, right? So you're still able to, you know, have the light sleep. You know, you may, you know, be able to, know that the patient is going through these cycles. Whereas coma, there is nothing. Okay. So unconscious and unresponsive. All right. And no matter what you do, you cannot arouse them at all. All right. So just remember, that's a coma. Now, here I wrote down like a little list exactly of what's happening first to the very end. So the first thing is you have your consciousness. You're very awake, right? You have wakefulness. Then from there you may get a little drowsy, right? Which we all tend to have. And one thing that I can say is that these first couple is what we kind of go through on a day-to-day basis, right? So the next one is a light sleep. You have light sleep and then you have deep sleep. And those two together is what they call REM sleep. Okay, so we do have cycles of our sleep patterns, right? Where we go in from light to deep, light to deep, light to deep, light to deep, right? And an example of that, in case you guys don't know, is, sometimes you set your alarm, you're like, okay, I'm just going to set it for five minutes, after you put it on snooze, and you don't wake up. You went right, you was like, man, I went back to sleep, and I didn't hear nothing until like probably 2-3 hours later, or maybe an hour later or so, right? And you may say, why was that? Because I had woken up, I was awake, and all of a sudden now, I snoozed the alarm and I can't wake up, or I didn't wake up until hours later, right? Because your body went back into a cycle of deep sleep, right? And sometimes in deep sleep, there's less consciousness than when you are light sleep. And for some people, they may only be a light sleeper, right? They can hear everything that goes on in the night. Every single thing, right? They hear the alarm, they can press snooze a million times, they're always going to hear the snooze, they're always going to hear the snooze, they're always going to hear the snooze, okay? So we kind of interchange between these cycles when we are sleeping, and that's REM sleep. And then finally, you have general anesthesia, okay, and coma. So literally, as you can see here, general anesthesia is bringing you as close to death as possible, if you can think of it in that way, in that sense, right? As close as possible, but still being able to bring you back, right? Because at the end of the day, yes, I may be able to bring you down to this area with medication, but I need to make sure that you can still get back to this point of wakefulness, right? Which is why anesthesia or anesthesiologists, their jobs can be tough at times, because they're responsible for the first 24 hours to make sure that this patient who came all the way down here with their level of consciousness can come back all the way up wherever the standpoint where they started. Okay, so that's the big thing here. And then literally right after general anesthesia, right, you have your coma patients, right, which are not able to have any consciousness or responsiveness at all. All right, so now with this type of patient, right, our nursing assessments is going to be, you have verbal response and orientation, right? So I'm going to assess those things, right? And how do I do that? By having you speak with me, right? Ask you, what today's date? Who are you? What's your last name? What's your first name? What's your date of birth, right? Who's the president, right? These different things. So that's how I test to see if you're oriented, right? Where are you? And that's how I get them to speak, right? And if you're not able to speak or anything like that, this is how I know that something is going on, right? So these are my nursing assessments, right? And then I'm going to check to see if they're alert, right? If I call you, do you respond? If I call your name, and there's some people, you call their name and they don't respond at all, right? So you have motor responses, right? How well are your motor function are working, right? And remember, that's also part of the neuro assessment as well. When you say squeeze my hands, can you wiggle your fingers? Can you wiggle your toes? Right? Are you able to resist against me? Right? So when it comes to neuro-wise, right, there's two different types, well, three actually. I'll say the last one later on, because that's when you'll see that's a late clinical manifestation that you would see in a patient. But the first two that I will discuss, you have the corticate and you have the cerebrate. So the corticate, right, is flexion and internal rotation. So the patient is pretty much positioned like this, right? And their feet are also inward. So they're like this, right? This is the corticate, right? And the cerebrate is an extension, or external rotation, right? So you'll see the hands like this, right? Away from the body, where you see the corticate is more like this, the cerebrate is more like that. And the same thing will follow with the lower extremities. Now, sometimes you may say, man, this thing is so close together, I may forget at times, right? The corticate, the cerebrate. Well, the corticate, right, let me get my marker here. The corticate has an I in it, right? So I, internal rotation, okay? And then this cerebri has an E, right? Hold on. Okay, erase my B here. Right? Has an E for external, or, you know, extension. Okay? So that's how, one way that you can kind of remember the trick that I use. The corticate, the I, right, for internal. And then you have the cerebri for extension and external rotation. All right? The next thing we have is my respiratory status. And remember, you may say, what does the lungs have to do with anything? Remember when I was discussing the brain, right? Really and truly, who's controlling the regulation of respiration, right? The pons and the medulla. So if anything is going to happen with respiratory wise, I know somewhere in that region something is going wrong within the brain, right? Especially the patient is not asthmatic, they're not a COPD type of patient, right? They didn't come in with any respiratory problems, right? No pneumonia, none of that, right? And they have, you know, altered mental status or anything like that, you know, I should expect something to happen with respiratory. So respiratory is not just only strictly dealing with lungs, but neuro does play a part with respiratory, right? And one thing, the respiration pattern that you can have with this type of patient, right, is Cheyne-Stokes. And you may say, what is Cheyne-Stokes? Well, Cheyne-Stokes, let's put an example here. All right, so this is my regular respiration, right? Goes up and down, up and down, up and down, up and down. And Cheyne-Stokes kind of looks something like this, where you'll be breathing a little bit, then there's a pause. Then you're breathing a little bit, then there's another pause, right? And this is an abnormal finding. This is not something that's normal. This is normal. This is not normal. Okay, and then I have my eyes. My eyes are going to change. And with my eyes, right, most of the time what you're going to find in a patient who has neural problems, right, they're going to have pupillary edema. And pupillary edema is pretty much the pupils, all right, or just the eye area is going to have a lot of fluid, right? There's going to be edema, and there's going to be pushing or pressure against the eyes, right? And you can either see the patient, they'll have the optic disc, right, is a swelling in the optic disc, and there's going to be progressive dilation and or fixed pupils. So here I drew, you have what normal eyes would look like, right? And if you guys notice, within the eye, you have your pupil, and within your pupil, you do have measurements for your pupils of what normal is. So a normal person, their pupil is probably going to be around 3 mm, right? And then an abnormal, which is what you will find in a patient who has neural problems, right? There may be a dilation, right? So this is a 3, this would probably be like a 4, maybe 5 or so, right? But there's a continual progression of a dilation. So here, and then eventually, ultimately, they may reach up to an 8, or they may reach to a 5, 6, 7, or whichever order. But as long as you see that, when you checked before early on the shift, you check again in 2 hours, you check again in another 2 hours, and you're seeing a slight increase in the pupils, right? That lets me know that there is swelling going on within the body, because these are the external findings that you are going to see. And then also too, if there isn't a progression, there may be one that's fixed and one that's not. And what fixed means is pretty much, when I shine the light, remember when you guys did your assessments, right? Your eye assessment, you're checking for perla, right? And you shine the light. There should be equal, round, reactive, right? And the eye should be accommodating, right? At least the pupil should be. But sometimes you may shine the light and there is no constriction going on at all. The eyes is just like this. No matter how much light you shine there, it just stays just like this. It doesn't constrict. And normally in a normal person, right, when you shine a light, the eye will constrict, because the eye is now modifying the amount of light that it's allowing to let in. So because there's light being put in, the body is going to accommodate and adjust and say, okay, I don't need to be that big because we have some light. And then when the lights go away, it says, hey, we need more light, so let me open up a little bit more, right? And a patient who have abnormal problems going on with their eyes, right, it may just stay just like this that's what's called a fixed pupil, right? Or they may say a pupil is blown. And you may say, not the fact that the eye has blown up, right? But the pupil itself has blown, which means that you have one pupil that is just dilated all the way. So you can almost think as if like that muscle that helped control has just completely given up, right? And that eye is just blown, right? The pupil is blown. And it'll look something like this. So sometimes they may be both eyes that are just, the pupils are blown, right? Or they may be one eye that may be okay, and the other eye is blown. And that will let you know where the problem is occurring on which side of the brain, right? And then here, you also have abnormals finding as well, if you see the pupil at least 1 to 2 mm. And pretty much, this can occur based on drug overdose or drug use, right? And with that, or alcohol or anything like that, any type of drug, you will see that the pupils are going to be different. And I'm just trying to show you the difference between like a 1 and a 2. Also, the book may show you some. You can also go to Google as well, and it'll show you the different sizes. I can honestly say you get better and better at knowing the measurements, the more and more you see it. Because sometimes you may question yourself, this is a 2, is this a 3, is this a 3, this is a 4, is this a 5, 6, and you may get confused a little bit, but the more and more I can honestly say that you practice on it, and you have those patients, and you're doing your eye exam, and you're looking at their pupil, you will then get to see the difference between what 5 look like, what 3 look like, what 4 looks like, especially if you're having a lot of neuro patients. You'll definitely be able to, I can honestly say, get better with time. Okay, this is not something that you just kind of go into and you just know, oh, this is this size or that's that size, right? You get better as you go. So these are also abnormal, but this is mostly because of drug induced, or if a person is on sedation, they're on medication that we're giving them, right? All these can play a part with the pupil reactions and sizes. But what I really want you guys to pay more attention to is the pupil dilation and the fixed pupil, okay? Because this is what you're going to find more with a patient who has pupillary edema. So the next thing that you're going to see on the nursing assessment, right? You're going to check your reflexes. So with your reflexes, one thing you want to do is do they respond to pain? So how do you do that? Right? You have the patient there, you want to squeeze their fingers, either squeeze their fingers, squeeze their toes, squeeze anywhere or pinch anywhere, right? Pinch as hard as you can. And sometimes you don't have to go as hard just because automatically you'll see them kind of jerk back, all right? And that's how you know that they're withdrawing from pain. So the body is still able to withdraw from pain, right? And that is a natural reflex. So again, you can pinch them, or you can squeeze their hands, right? Squeeze their toes, just to stimulate some type of pain to see if they withdraw, right? And if you're squeezing as hard as you can and there's nothing going on, then that means that reflex is absent, because they should be able to at least pull back, withdraw, right? So the next thing is your Babinski test. Now, remember when you guys did the health assessment and you guys are going over that part where you pretty much lay down. They take just an object or so. Most of the time it was like a metal, like scalpel, something of that sort, or a blade, not a blade, but like a pen or something of that nature, right? And they strike it against the heel of your feet, right? Like this is your feet, and they'll just go like this, right? Go up. Normally when they would do that, right, then the body natural response is to go down, right? It should go down. When it comes to babies, at least 2 and under, when you do that, it will go up, right? Because neurologically, their brain is not developed enough to, do the normal reflexes. So within the ages of 2, that is normal for them. But once they get older and they get beyond that, eventually when you stimulate them, the toes are supposed to curl down, right? So a positive Babinski test is when the toes are curled up, right? It should not curl up. That lets you know something neurologically is going wrong, right? It should go down. So a negative test, which is what we want, right? Because we want to make sure that you're normal, right? Your toes should point down. Positive test, right? The toes are pointing up. The next reflex that you have the coronal reflex test. And pretty much what that is you just pretty much almost like a dart, but you're darting in different areas of their eye, and each time you do that, they should at least be blinking, okay? So, and you can even do it with your friend. I remember doing this back. It's like, oh, let's see if you can blink. Oh, let's. I mean, not see if you can blink. Let's see if you can not blink, right? And they'll just kind of like go real fast in your face. That's pretty much what this test is, right? And the positive finding that you should find, which is in a normal person, is that you should blink your eyes, right? And that's your body's natural way of protecting itself, right? So these are natural reflexes that the body does to protect itself. And if you're not doing these functions, right, then that lets us know, hey, something is not right, right? The fact that you can just go just like this and your eyes are not blinking at all, okay, that's a problem. You also have your gag reflex. Or I put swallowing so that way you know that that's what that consists of. So your gag reflex, right? You should be stimulated when you have saliva in your mouth, whether either you're going to swallow. So this is why I say drooling versus swallowing. If you're drooling, that lets us know that you're not able to swallow, because all of that saliva should not be coming out of your mouth, right? At least in a normal person, it doesn't come out of their mouth. You swallow it, or you may spit. But either or, you should have a gag reflex. So a patient or someone who doesn't have a gag reflex, that's a problem. Then you have your deep tendon reflexes, and this is the reflex that we always hear about that the doctors does or they do from time to time. Very rare do I go to appointments now and they do that, but they can. And what they do is pretty much they will take a tool and they will hit against your knee, right? Or they may hit against your elbow area or so, and they tap to see if your legs will jerk up or your arms will jerk, okay? And that is a natural reflex that the body does. So if there's an absence of that, again, that will also let you know that, hey, something is wrong. So as you're assessing these things, these nursing assessments, you want to be taking notes that, hey, is this a positive finding of, someone who having neurological dysfunction, or is this a normal finding of, okay, this is just what a regular person does? All right, and then last but not least, posture, which I mentioned it before in the motor part, right? But now posture is how you are. And with posture, right, you have three different things that's going on. You have the corticate, you have the cerebral, and then finally flaccidity. And it goes directly in that order. So the corticate, like I said, in. Remember the I for the corticate, I, in, right? The cerebral, you're going out like this. So pretty much there is an extension. And then finally, flaccidity, which is the worst. And flaccidity is there is no muscle tone whatsoever, right? And you don't want to ever get to this part, because that pretty much means that there's no tone, there's no movement, there's nothing going to be there. All right? And this is when you know that this patient is no longer functioning, at least within the motor part of their body is completely gone. So now the next thing we're going to talk about is the Glasgow Coma Scale, also known as GCS. Now with the Glasgow Coma Scale, it's separated in three parts. So you have eye opening response, best verbal response, and best motor response. So pretty much you can break this up as eyes, mouth, and hands, right? So with this said, you have different responses here that the patient should be able to do, and then they get scored accordingly. Okay. Now here with the eyes, right? We should be able to have a spontaneous movement with our eyes, right? Which pretty much we do all the time. We blink, we turn, we look at different things, right? Then you have where people are only their eye only moves based on speech. So if you were to call their name, then they'll open their eyes, right? But just spontaneously, they're not doing anything. Right? Or to pain. When you pinch them, they open their eyes, right? Or if you squeeze them. And then finally, for no response, you give them a 1. So a lot of times people get confused with the Glasgow Coma Scale because they think that if you have no response, right, you should get nothing. But that's not how this score is worked. That's not how it works, right? If you don't have anything, you get at least 1. All right? So you get a 1 in this category. The next thing is your best verbal response. And the best verbal response is that you're oriented to time, place, and person, right? So you'll get AO times 3, which I discussed before earlier. Then you have where the patient can be confused, right? Or they have inappropriate words. And inappropriate words doesn't mean that like they're cursing or anything like that. Inappropriate words mean like if you ask them, what did you have for lunch today? And they start talking about computers, right? And then you're like, okay, what does that have anything to do with what were you eating or what did you have to eat, right? Or you may ask them, how do you feel? And you're talking about clothes or pretty much inappropriate. That's what it means with inappropriate, okay? And then incomprehensible sounds, right? So sometimes you may not even get a word out of them. All you hear, right? You hear grunting, a lot of garbled speech, right? Things that you just cannot comprehend or understand what they're saying, right? And then finally, no response at all. They're not able to speak. And again, no response, they're going to get what? 1. And then last thing is your best motor response, right? Your best movement. What are you going to do? So, obeys command. Now, this doesn't mean like, oh, you have to listen to everything I say, right? That's not what we're talking about. We're talking about, can they follow simple commands as far as, can you squeeze your hands for me? Can you lift your hands up? Can you elevate your leg? Can you push against me for resistance, right? Can you wiggle your toes, right? Can you open your eyes? Can you puff out your cheeks, right? These different things that we've learned in health assessment, right, is pretty much obeying commands. The next thing after that, right, they may move to localized pain, right? So depending on where the pain is at, they'll move to that area. And a lot of times when we have abdominal pain, the first thing we want to do is either crunch down, right, or turn to the side of our stomach. So if you can at least see them do that, right, they'll get a score of a 5. You have flexion, withdrawal from pain, right, which we talked about before. When you actually pinch them or you squeeze their hand, they should be withdrawing, right? That's something that's normal. And then if they have abnormal flexion, right, which we know as dyscerebrate, right, because they have the internal flexion, right, and they should not have that. And then you have the abnormal extension, which is the dyscerebrate, right? So the corticate is bad, but dyscerebrate is worse, right? And then finally, the worst of all of them is flaccidity, right? Which is there is nothing, there is no muscle tone whatsoever. So then last but not least, you have no response, which no response, we know they get what? 1. And I keep saying that over and over because there will be questions on the test where they say patient has no response, no response, no response to each category. Should they get a score of a 0, right? And that can be a true or false question, or there may be a multiple choice question and they will actually have 0 as a choice. And because you're thinking they're doing nothing, then they should get nothing. That is wrong. They are going to at least get 1 point for that. All right, so here with the scoring system, right, it pretty much goes down the list, right? It's very self-explanatory. 4, 3, 2, 1, right? Then 5, 4, 3, 2, 1, and then 6, 5, 4, 3, 2, 1. Now, one way to remember how the scores were distributed, right? I used to think of it like this. With your eyes, right, you have 4, meaning as far as when you had on glasses, a lot of people tease people saying you have 4 eyes, right? So you know you have 2, but think of it this way: with eyes, you have 4, right? Think of those people with those glasses, you have 4 eyes, right? So 4 eyes are going to start the scale with 4, right? And then from there, once you remember 4, the next one is going to be 5, and the next one is going to be 6, because you already know it's going in descending order. So what you really need to know, right, is the start of each one. Once you have the start number of each one, you already know it's going to count all the way down to 1, right? So if you know you have 4, you have 5, and you have 6, well, 4 plus 5 plus 6 is going to give me what? 15, which is my highest score, right? So my highest score is going to be 15. My lowest score is going to be 3. Those are like some really, really, really common questions that they like to ask when it comes to Glasgow Coma scale. Very rarely when I was throughout nursing school did they ask any question as far as, oh, to speech, what kind of score would you give? So you didn't really have to study each thing in here. And I remember doing that, and I was so ready for the test, and they asked me questions of, what was the lowest score? What's the highest score, right? And I was just like, really? That would have saved me a whole bunch of time. So I'm not saying not to study it, because again, I was anal, so I always like to at least cover. So I always say at least cover it, but just remember your main common questions literally came from what was the highest score, what's the lowest score of the Glasgow Coma scale, okay? And if you need to know the highest score, a way to remember is knowing that eyes, right? When a person wears glasses, I got 4 eyes, right? And then from there, once I know this top number, I already know the rest, right? Because it goes 4, 5, 6, and everything else is condescending after that. So once I figured that out, I knew what my highest score was, so that when you saw the question, you knew how to answer it. Okay, now as you can see here in this little bubble, right? These are the main important things that you need to know. Of course, still study this, but again, just remember the highest score and the lowest score. All right, those are very, very common questions. Also, too, this is for your knowledge, your benefit. I didn't really see any test questions on these, but it's still good to know because when you get out there into your clinical setting or when you start working as a nurse, it's very important to know. So you have a thing that's called OPO, which is also known as Life Alliance, and this is generated through University of Miami Hospital, and pretty much what it is organ donation. All right, so we already know if a patient has a score of 3, you definitely got to call them because their organs may be intact, right? It may be good, it may be viable. So make sure you follow your hospital policy on when you need to call OPO or Life Alliance, which is pretty much just the organ donation people, right? When you need to call them. And at least for my hospital or so, we start calling them like around an 8, a score of an 8. So 8, 7, 6, 5, 4, 3, 2, 1. Well, not 1 because there's no 1, but anything between 8 and 3, we normally will call Life Alliance just to kind of give them a heads up, like, hey, we have this patient here, they're not doing so well, this is their Glasgow Coma scale, and we just pretty much give them the information, and then we also call back again once they have deceased, and then we'll call them again. We have 1 hour, and this is everyone. All right, you have 1 hour to call Life Alliance once that patient or person has passed or expired. We say the word expired, we don't say death or passing, we say once the patient has expired. Okay, so you have 1 hour to call Life Alliance about the scores, and then again, if they want to be a candidate for organ donation. And again, us as nurses, we do not talk about organ donation to the family members at all. We do it strictly through Life Alliance, and Life Alliance would then go ahead and talk to the family member of that patient. Okay, we do not ever talk about organ donation to the family member. Now, of course, when we get into history, you may ask them, would you like to be organ donor? That's fine. But as far as, oh, you need to donate your organs, or let me call the number, this and that, and you're saying that right in front of the patient's family member, that is a big no. All right? And the reason for that is because, let's say you're the nurse that's the nurse for that patient, right? This patient family member, they're going to be distraught, they're going to be hurting, they're going to be depressed, maybe in denial, anger, have some type of anger, right? Because of the patient expiring. And the first thing is that they're hearing from their nurse who was taking care of this patient is, you want to put the organs up for donation now, or whatever the case may be. They're going to look at it as, did you do everything in your might to take care of this patient, or are you just more interested in the organs, right? So that's how we kind of just stay outside of that arena, because you don't want to be the same person who's a caregiver, the same person who's now talking about organ donation, because in their eyes, they may look at it as, you didn't do everything that you needed to do. You were more concerned about getting the patient's organ than you were trying to save my dad or save my mom, okay? So again, you will follow your hospital policy on when you will need to call OPO or Life Alliance. All right, you don't have to remember the number. They give you a card, and it's on the back of the card, so it's pretty much self-explanatory. And you do that, when the patient has a poor prognosis. So now we're going to talk about the complications of what's going to occur in a patient who has a disturbed level of consciousness. Okay, so again, it's not because of the fact that they are unconscious, but the things that are happening behind the scenes that we cannot see, right? The things that's coming up on the surface is going to show decreased level of consciousness, but we're trying to figure out why is that. So remember when I was showing you guys the picture with the structure of the pons, you had the midbrain, right? You had the medulla, right? You have certain components that regulate certain things. And remember the pons and the medulla help to regulate respiration. So within here, one of the complications that you can have, right, because either somewhere in those areas of the brain is not working or has some type of dysfunction, you're going to see respiratory distress or failure, all right? And this is a big key component that I want you guys to remember, because as you guys remember ABCs, right, you have airway, breathing, and circulation. Those are your major things that you want to watch out for. So if you don't have a patient who has, you know, other problems or whatever, and they also have respiratory problems, you want to make sure that you address the respiratory problem first, because a non-breathing patient is no patient at all, and you want to make sure that that person is still breathing and still thriving and still able to at least do something, okay? So you can have respiratory distress in either one lobe, in one of the lungs, both lungs, or it can just be a lobe, okay? So you just want to be aware of exactly what's occurring, what's taking place, all right? As far as pneumonia, okay, which is also another lung problem too. And sometimes we hear the word pneumonia and we're like, you know, yeah, I know pneumonia, but what exactly is pneumonia, right? So pneumonia is pretty much a lung inflammation, right, that's either caused by bacterial or viral infection, right? And it can be because of pulling up of fluids, not being able to get all of that fluid out, right? And eventually, what type of habitat do bacterial or viral infections love to have? Dark, moist areas, right? And the lungs is already it's dark, you know, and it's gonna be moist because you're exchanging different things, or it can be a failure of those things because you have fluids backing up. But pretty much it's inflammation of the lungs based on viral or bacterial infection, okay? And that's pretty much what pneumonia is. You also have aspiration, all right? Aspiration is a complication that can occur. Why is that? All right. First, you may say, what is aspiration? I remember when I was in nursing school, when I first heard it for the very first time, I said, what is aspiration? Don't really know anything about it. The only aspiration that I knew about was when we did in skills and you had to aspirate the syringe or so. So when I'm thinking about aspirate, it was just so weird to me because I didn't hear this terminology before. So aspiration is pretty much inhalation of materials, right? It doesn't matter what type of material. It can be foreign material or material that your body knows, right? But it's going in the wrong place. So it's inflammation of the material or fluid in the lungs, all right? So pretty much this aspiration is just a fancy word to say to choke, right? Eventually I figure out that's what that meant, is that the patient can choke, right? Because at the end of the day, what happens when something goes down the wrong tube, right? When things are going down the trach instead of the esophagus, you start gagging, you start choking like crazy, right? Why? Because things are not supposed to go down the trachea, only air. So when you have certain materials or fluids going down the wrong air pipe, the wrong tubing, right? It is going down the air pipe, right? You're always going to have a risk of aspirating and choking. And then the other definition that we kind of already know, because from scales, is drawing up of something, in or out or up, through or by suction, okay? So when you have your patient who has your thoracentesis or paracentesis, right, they're going to be aspirating those fluids, okay? So that's another terminology, or same terminology, just different definition, okay? So when we're talking about aspiration, we're talking about the one to choke on something, okay? Now the next thing you have is your pressure ulcer. Now with pressure ulcer, you have 4 different stages, and then you have one extra one. So you have stage 1 through 4, right? And then you have your unstageable. Now, stage 1 is pretty much just redness of the skin, right? The skin is still intact, it's just redness. Stage 2, there's an actual broken skin, okay? So there's a tear or there's something that now your epidermis layer is now removed and it's exposed, okay? Stage 3 is getting into where you can see the subcutaneous layer, all right? Which pretty much subcutaneous is just the fat layer. And then finally you have stage 4, which stage 4 is going into the muscle, deep tendons, or actually the bone itself, okay? And that is stage 1, 2, 3, and 4. Now, the unstageable one is where you're not too sure if it's a stage 1, stage 2, or stage 3, stage 4. You don't really know, so you just label it as it's unstageable, right? And then you also have one last one, which is called DTI, which means deep tissue injury. And pretty much what that is there's not a break in the skin, but you may see like a maroon or purple-ish area on your skin. And pretty much the tissue underneath is dead or it's dying. Okay, so it can be necrotic or so, but pretty much the skin is still intact, but underneath the surface of the skin, it is damaged. Okay, so deep tissue injury, all right, DTI, and pretty much the skin underneath is damaged, and there's nothing you can really do but kind of like position, rotate, different things like that. All right, and then you have deep vein thrombus, which is also known as DVT. All right, and what DVT is pretty much is a blood clot. All right, and it's a blood clot that either happens somewhere below the calves area. They can happen different places, but the most common is in the calves area, and you'll hear the patient complain of a lot of pain in the calves. You may see redness in the calf, swelling in the calves, right? You may even see DVTs on the upper extremities. You can find it in the groin. There's different places you can get DVT, so I don't want you to get stuck on it's only in the calves, but that's just the more common area of where you can get a DVT. And what they're going to do to see if it's a DVT or not, they're going to do an ultrasound Doppler test, okay? So ultrasound is going to come in, and they're going to go ahead and do the Doppler test, and then they're going to see whether or not there's a clot there indeed. And if so, then the test will be a positive Doppler, and they'll let you know exactly where the clot is located, okay? And then from there, whatever interventions that the doctor would like. And some basic interventions that they would like to do is pretty much an IVC filter. And pretty much what that is just an insertion of a filter to kind of catch the clot so the clot doesn't end up in the heart, the lungs, or the brain, right? Because you can have MI if it goes into the heart, and you can have a pulmonary embolism if it goes into the lung, right? Which is, I think, what's that basketball player? Chris Bosh, that's what he had. He had a PE, right? And then you can have the clot can travel up to the brain and cause an ischemic stroke, which I'll also talk about that in my next lecture, okay? So DVT, something to take very serious, okay? And then last but not least, you have your contractors. And contractors, I always like to say it goes coincide with pressure ulcers, okay? And the reason why I say that is because if I have a patient who is contracted, which contracted pretty much means that the patient has a shortening of the muscle tissue or tendon and they have rigid areas, okay? They're not able to move, you know, and sometimes you'll see them contracted in the last position that they were in. So sometimes you may see the patient and their arms are locked like this, and you will try to stretch it out and it will not go anywhere. Why? Because that muscle tone of, not muscle tone, but that extension of what the tendons would do, right, is no longer there. So it would just pretty much kind of stay locked. Same thing with the legs. If they're bent a certain way, it's going to be locked. And that's what they call is contracted, okay? And there's nothing, once it's contracted, there is no reversal for that, okay? So if you have a patient who's contracted, they're not able to move, especially with their lower extremities or their upper extremity or the whole body, right? You're going to be more prone for pressure ulcer because what's causing the ulcer? The pressure, right? Pressure on one leg, pressure on the other leg, pressure on the sacrum area, right? These are areas that are very bony, right? And when they are bony like that and you have a whole bunch of pressure on it, it eventually opens up the skin, right? And that's how you get the pressure ulcer. So one of the key things into preventing pressure ulcers is always making sure that you rotate the patient, especially if the patient is already in that stage where they're contracting. So now we're talking about the nursing diagnosis, right? So these are some of the nursing diagnoses that you're going to find in a patient who is going to have an altered level of consciousness, right? Or have some type of neurological dysfunction. Number one, and I cannot stress enough, is going to be ineffective airway clearance, right? And I don't know if you guys remember a little thing called A, B, C's, right? I don't know if you can see that. ABCs, right? You have my what? Airway, right? Okay. So as you can see on the ABCs, A, aide trumps everything, right? You are not alive if you do not have an airway, all right? So you may think that, oh, but we need to pump or whatever, you know, we need blood, we need this, we need that, we need circulation going. It does not trump airway, because if I'm not breathing, I am not a living patient, okay? So that is the first thing that you want to make sure that you are aware of. Again, risk of injury, right? Why risk of injury, right? What caused the level of consciousness, right? The altered level of consciousness. It could have been, you know, a tumor. It can be they had brain trauma, brain injury, right? Which I'll go over on another lecture, right? But these are the reason why you can have risk of injury, and then it could be a risk of injury for other things that can occur based on a complication that can arise from having level of consciousness, which, you know, we can have motor function that is deteriorated, right? Because all of these things does occur. Again, you have deficient fluid volume, right? You have impaired oral mucosa, right? So you want to keep the mucous membrane moist. And a lot of times when you see these type of patients, it'll be dried out, okay? And then there's risk for dehydration. There's risk for broken skin, right? Or scabs or things like that. Again, another one is ineffective thermoregulation. And I highlight this one not because it trumps any of these, but the fact that you're going to see this as one of your early onset, your late onset clinical manifestations when it comes to neural problems. Okay, so that's why I highlighted that one there. The next one you have impaired urinary elimination and bowel incontinence. And you may say, what does the bowels have to do with this, right? Well, remember when we were first discussing the brain and I showed you the different compartments of the brain. You had the pons, you had the midbrain, you had the medulla, right? There are different functions within those systems that also plays a part with your bowel functions and your urinary elimination. So if those areas are damaged, these areas are going to be affected as well. All right. The next thing you have is disturbed sensory perception, right? And that's a given because at the end of the day, they may not know their surroundings, be aware of their surroundings. They may not have those reflexes intact. The pain reflexes, withdrawing from pain, different things like that is going to be altered. So their sensory perception of things is going to be disturbed. And last but not least, interrupted family process. Now you may say, oh, you know, how, in what way? Well, remember, these are people's loved ones. They may not be your loved ones, you know, and you may see it as just another patient or another number, but for some people, it has, you know, there's a name attached to that person, right? There's meaning from that person, you know, whether it can be someone's mother, someone's father, someone's sister, brother, whatever it is, that family process is going to be disturbed because now they're seeing their loved one not able to, you know, carry out normal functions that they were carrying out before. Okay, but again, number one, ineffective airway clearance. A lot of times you're going to see a lot of questions about the airway, okay? And sometimes you may want to say, oh, but you know, the heart is more important than the respiratory, which, you know, at sometimes it can be, but if you ever see a question and an airway is an answer, I'm telling you 99.9999% is going to be ineffective airway clearance, okay? Remember your ABCs, all right? ABCs, all right? So most of the time it is going to be your ineffective airway clearance, okay? And since we're on the topic of test questions, also two common ones is going to be hand hygiene, hand washing. Don't matter what the question is. If you see that choice, nine times out of 10 is going to be hand washing, okay? And I really want to say 10 times out of 10, but because we don't live in a perfect world, there is no perfect absolute number, but I'm telling you it's going to be hand washing. And if you see another question with potassium, I'm telling you 9 times out of 10 times, the answer is going to be potassium. Those three things, airway, hygiene, hand hygiene, and potassium. Most of the time, those are the answer, all right? So just be aware and know the different things that can happen with an ineffective airway clearance and be on guard for those. Now we're going to talk about the care of a patient with altered level of consciousness, right? So as we talked about earlier, when you had the nursing diagnosis of what you're going to watch out for, what things that you can diagnose the patient with, right? As you can see, what happens in the nursing diagnosis is exactly the care that you want to give so you can kind of prevent those nursing diagnoses from occurring. All right, it's a big tongue twister, but just bear with me here, okay? So you have your maintenance of a clear airway, right? Remember, one of the things that can be a problem is what? Respiratory failure or respiratory distress, right? And one of the nursing diagnosis was ineffective airway, right? Respiratory airway. So one thing that I want to take care of, right, is a maintenance of a clear airway, because if I can maintain a clear airway, I just eliminated that nursing diagnosis. And then I also eliminated that complication of respiratory failure. So you guys kind of understand what I mean when I say they kind of go hand in hand. So a lot of times you can kind of see what you need to do as a nurse based on your nursing diagnosis and based on your complications, because our goal, remember, as healthcare professionals and us providing care to the patient, is we want to cause no further harm and to maintain an optimal quality of life, right? And how we do that is by pretty much trying to prevent the complications of what can occur through these disease processes or altered level of consciousness or different disruptions or dysfunction that is going on within the body. All right, our main goal is to kind of prevent or maintain any of those things from occurring. All right, so the next thing is protection of injury. I don't know if you remember, but remember we had a nursing diagnosis, it was risk of injury, right? So if we protect from injury, and then that kind of eliminates there to be some type of injury, because we're constantly watching out for those injuries that can occur, right? Again, we had a nursing diagnosis of deficient fluid volume, right? So what do we want to do? Make sure that we have a good attainment of fluid balance, right? So we want to make sure, hey, if this patient is putting out way too much in their Foley, or they're putting out way too much urine, they're voiding way too much, and they're not getting that that fluid back, you want to make sure that you are balancing out the fluid that's going on, okay? Maintenance of skin integrity, right? Because we had a nursing diagnosis of impaired skin integrity. So if we're maintaining the skin, right, constantly we're rotating them every 2 hours, we're keeping them off of their bottoms, we're pretty much evenly distributing the weight, every 2 hours, right? This also prevents one of the complications, which was pressure ulcers, right? Also, the absence of corneal irritation, right? So you want to make sure that the eyes are fine, that they're intact. You want to make sure that they don't have the edema going on, because again, early signs of pupillary edema is going to cause blurry vision and different things that's going to be wrong with the vision. So you want to make sure that there's an absence of corneal irritation, no irritation is happening, because then you rub your eyes get red, get irritated, it's already swelling, right? And the vessels are so tiny they can just rupture, all right? You don't want that to occur. Also, you have effective thermal regulation. Remember, we had a diagnosis saying ineffective thermal regulation. So again, you want to make sure that the patient body temperature is at the optimal level where it needs to be, and that it's normal, right? A normal body temperature is 98.6. So you want to make sure it's somewhere within that bracket. If you see that they're having a fever and it's 101 or 100, 100.4 or whatever it is that's not in the normal limits, you want to make sure that, hey, whether I'm giving Tylenol, I'm giving ice packs, right? Or we're letting the doctor know if they need to be on a cooling blanket, right? And then also too, because it can be the flip side. Maybe the temperature may not go up, maybe it may be down, right? And they feel very cold, where you may want to give them a warming blanket, okay? So there's different things that you want to kind of watch out for and kind of monitor and take care of, so that way it prevents complications from occurring. Also, accurate perception of the environment or stimuli. So you want to make sure that when you're stimulating your patient, and you're letting them know the accurate information. So if they tell you, it's July, when it's May, you want to let them know, say, hey, no, it's May 2017, not 1987, or, whatever they may blurt out. So you want to make sure that you're giving them an accurate perception. Hey, you're in the hospital, all right? You're not at home, you're not at church, because sometimes you get the weirdest thing. I remember one patient said he was at home, another one said he was at church. He said, come in church with me, sit down right here, because these patients, they have an altered level, a level of consciousness. Okay, so for us, we may look at it like this is just, you know, 1, 2, 3, you know, and it's simple. But for these people who have these dysfunctions, it is not. So you want to make sure that you're constantly, you know, giving them the right accurate perception of the environment that they're in. Okay. Also, you want to maintain an intact family. Remember, we talked about a diagnosis about disrupted family process, right? So you want to engage the family as much as possible. Let them know what's going on. You know, teach them different things. Let them get involved in the health, right? That always can kind of help. So then that way the patient, family member can be more engaged and more involved in knowing exactly what care they're getting for their family member. All right, and then absence of complication. The biggest thing we try to prevent is absence of complication. Now, I'm not saying that you're going to be the super nurse and you're always going to have a patient that doesn't have any complication, and that you're always going to make sure that you do all of these steps and nothing is going to happen, because that's not true. Okay, you can do as much as you can. You can be the best darn nurse there is out there, but if the patient health is declining, there is nothing you can do in that aspect but just try to comfort the family, be there, and let them know, you know, every step of the way what's going on. All right. Of course, if the patient has given permission ahead of time, because you don't want to get involved with HIPAA violation. Okay. So as long as the patient gave clearance beforehand, before the level of consciousness happened, and that they had a healthcare proxy or they have someone to make decisions for them, then you will talk to that person and let them know what's going on. Okay, but I'm just letting you know, just doing some of these things can definitely prevent some of those nursing diagnoses that we talked about earlier, as well as some of those complications as well. All right, so now we're going to talk about the unconscious patient. So what it is to be an unconscious patient is pretty much they're hard to arouse, right? And they may need to be aware of his or her surroundings, okay? So that's one thing with an unconscious patient. They're not aware of their surroundings and what's going on, and then as well as they're hard to arouse, okay? And this can happen in many different ways. The main common way of an unconscious patient is, one, it can be airway loss, and pretty much the patient has to be intubated, and now they're on a machine, they're going to be on sedation, so now they're unconscious. Not because they came in unconscious, but the effects to try to reverse and to help them causes them now to be in an unconscious state. And that's just one. Okay? Here I put a list of different reasons why you can be an unconscious patient. Okay? And the main common one is you have head injury. Okay? And if you notice with head injury, you have concussions here, you have skull fractures. Okay? You have cardiac arrest. All right? Drug overdose, hypo or hyperglycemia. All right, so if you guys want more information about hyper and hyperglycemia, please check out my diabetes lecture, and you will find all the information you need to know about hyper and hypoglycemia. All right, we also have cerebrovascular disease, also known as CVA, and pretty much that is a stroke or hemorrhagic stroke or ischemic stroke. And then you have blood loss, right? Or you can have a hematoma. Poisonous fumes or gases or substances, right? Epileptic, which is pretty much a prolonged seizure, and I'll talk about that in my next lecture. And then you have fainting, and you have asphyxia, which is also known as choking. All right, so these are all different ways of how a patient can become unconscious. All right, so it's not just only one factor, but you want to know whichever factor it is, right, that caused them to be unconscious. Sometimes just by you reversing that factor can help them gain their consciousness, okay? So a drug overdose, right? Just for example, drug overdose, and the patient is unconscious, one medication that they give to reverse the effects of feeling high is Narcan. And once they give the Narcan, that will slowly but surely start waking up the patient, all right? Again, if it's because of hyper or hyperglycemia that the patient is unconscious, either you give them sugar or you give them insulin, okay, and that will help. So depending on what caused the unconsciousness, if you fix that factor, most of the time you can bring them back into consciousness. Now, as when it comes to these type of causes, whether it's head injury, skull fracture, concussion, cardiac arrest, right, these are a little bit more serious, or epileptic seizures, right, because they cause more damage. All right, so because they've caused so much damage, sometimes you fixing those damages, it has gone to the point of no return. All right, but for the most part, if you think about it, whatever caused your patient to be unconscious, sometimes just fixing that factor can bring them back. All right? Okay.